Welcome. I'm going to be talking about opioids and the statewide prescription drug monitoring programs, specifically the legal provisions, dealing mostly with state, and just a brief touch on a few federal provisions. So first, I want to say that I work for the Network for Public Health Law, and we are an organization that's funded by the Robert Wood Johnson Foundation. We provide technical assistance, training, resources, opportunities to build connections within the field of public health law. And we have a website. You can join the network and get our resources, updates on our resources for free. So if you're interested, please go to our website and join. And also, my fine print, the presentation, this is just informational. I'm not your attorney. This isn't legal advice. So if you do have further questions about how the law applies to you, consult with your own counsel. Okay. So prescription drug monitoring programs are state-run databases. They are meant to track the dispensing of controlled substances. The dispensers, such as pharmacies, then submit information related to the dispensed controlled substances to the database. And the database is accessed by authorized individuals and entities. Those accesses are generally governed under state law. The legal objectives of prescription drug monitoring laws there are few. There's supporting legitimate medical use of controlled substances. There are, those who need access to these, and we want to make sure that that access is available and that prescriptions are not being abused. So the next objective is to identify and deter or prevent drug abuse and diversion, so to ensure that prescriptions aren't being written when they shouldn't be, that drugs are not getting diverted. Facilitate and encourage identification, intervention with, and treatment of persons addicted to prescription drugs. So to make sure that we have better tools to identify those needing assistance with drug treatment programs. And informing public health initiatives through outlining the use and abuse trends to improve programs like the prescription drug monitoring program, but also improving public health response and treatment programs available throughout the state. So I'm going to talk about a few of the what I would consider more important provisions of state prescription drug monitoring laws in combating the opioid crisis, but also those concerned with data sharing and the use of information and rights. So prescriber use mandates, I'll talk about those first, and then move on to confidentiality and the right of access to information in the database. And then I'll talk about using de-identified information from prescription drug monitoring programs, databases, and then talk a little bit about interstate data sharing of PDMP data. So, prescriber use mandates. Currently, prescriber use mandates are state laws that require healthcare providers to check the PDMP database under specific circumstances. So comprehensive mandates generally apply to all prescribers and generally at a minimum to all initial opioid prescriptions. And these have been associated with reductions in the number of opioid prescriptions and multiple provider episodes. So when patients visit numerous prescribers or pharmacies to obtain the same or similar drugs in a short time span. So the Pew Trusts did a lot of work looking at state laws in this area. And so these maps are from their website, and it's, I think, a very good website. There are some additional things on the website if you're interested in how the laws vary across states. So this particular map is showing the type of mandate that states have. So whether or not the mandate applies to all prescribers or at least all initial opioid prescriptions. And so you can see that in 19 states, it applies to all prescribers and all initial opioid prescriptions. In 18 states, it either doesn't apply to all prescribers or it doesn't apply to all initial opioid prescriptions. And then 14 states have no mandate at all. So there's quite a bit of variation in this area across the country. And then the next map shows the drugs that are included in each mandate. So you can see that there's even greater variance in what types of drugs are included. There's DEA Schedule 2 and 3, only one state covers that. There's only Schedule 2, 2 states. Schedules 2 through 4, there are 3 states. Schedules 2 through 5, 7 states. And then 24 states have some other scheme that's defined in state law that isn't covered under those. And then 14 states, again, have no mandate at all. On this map, you can see another important provision in prescription mandates, timing triggers. So when the prescriber is actually required to review the prescription drug monitoring program for the initial prescription for drugs that are subject to the mandate. So you can see in this one, there are 33 states, so a much larger percentage across the country that are requiring all prescribers to look at initial prescriptions. And then 4 of them that don't have to look at initial prescription, and then 14 with no mandate again at all. Okay, and then another timing trigger is the prescriber required to review the prescription drug monitoring program database at regular intervals after the initial prescription. So this is a pretty important provision if you are looking to prevent drug shopping between pharmacies or doctors going to multiple doctors. And so 26 states currently have a requirement that prescribers have to look at the database to see after an initial prescription. 11 currently don't, and then again, 14 have no mandate at all. And some common provisions within, common exceptions to prescriber use mandates include short-term prescriptions. So those are generally prescriptions lasting less than 14 days. Prescriptions for terminally ill patients are often exempted in state laws. Prescriptions that are issued or administered at hospitals and long-term care facilities, obviously these are under the guidance of physicians or others that are prescribing, and so they're considered to be less likely to be abused. Prescription, when the prescription drug monitoring program database is inaccessible for whatever reason by the physician or the prescriber, then that might be an exception. There are a lot of other exceptions, and they vary really greatly between states, across states. Some of them that include like cancer patients, veterinarians in the case of emergencies, but each state seems to have their own exception that's different from any other state as you go through these laws. And so you can't really in this presentation list them all, but I think it shows that there's a lot of inconsistency and then somewhat of moral judgments as to who should have easier access to these prescriptions, who should have less scrutiny. And so I think that's an interesting thing to consider as states move forward with additional laws in this area. Okay, so confidentiality of prescription drug monitoring program data. This also varies very widely across jurisdictions. It's just not consistent in any way. And persons or entities that are entitled to access to receive data from the prescription drug monitoring program are determined by state law. There's nothing federally in this area. And so the most common areas that individuals that are authorized to access the data are licensed physicians and others with the authority to prescribe substances, pharmacists and others with authority to dispense substances, designated law enforcement officials, and then professional or occupational licensing, certification, or regulatory boards, commissions, or agencies. And so you can see from this that there's a lot of people that might be left out that have a potentially legitimate use for this information. There are some that have specific public health exceptions. I think it varies quite a bit because it depends on what agency is charged with running the prescription drug monitoring program. If it's housed within public health, then those states generally don't have an exception. But the monitoring program can be housed in other agencies, and so you might see additional exceptions, or not exceptions, I apologize, authorizations for access to the database. And there are some common statutory safeguards that are pretty consistent across the states. And these include designating prescription drug monitoring databases as confidential and exempting them from public records or open records laws, FOIA requests, and sunshine laws and the like. And this is particularly important to safeguard the confidentiality of patients, and also delineating who is allowed to access the PDMP, as I said on the previous slide, and under what circumstances those individuals are allowed to access and for what purposes. So if we go back to this slide, these individuals might have access, but the circumstances under which they get access and the timing under which they get access might vary, depending on their uses of the information. And also, states explicitly require state agencies to comply with all relevant and state federal laws. And so whether or not certain laws apply, I think I'll talk a little bit about the federal scheme and when certain laws apply, but it might vary across states depending on where the database is housed. I think that's often the case. Penalties for unlawful access or disclosure of PDMT data is another common safeguard. So and then there's the instance of providing de-identified prescription drug monitoring data. So generally recipients of de-identified data from the database is determined under state law. And the instances for de-identified data releases generally for research and statistical purposes. And so information might be released to researchers, but only in a de-identified form. So the researchers aren't listed under the authorized access, and so the agency is generally providing de-identified data for statistical analysis and research. And it can be limited to certain state agencies or employees for statistical purposes or for trend analysis. So in the case of health departments, state health departments and the like, their access might be limited just to de-identified data as well. and the interstate sharing of prescription drug monitoring data. So states share information from the database with other states and authorized users in other states or both. And there is a National Alliance for Model State Drug Laws study that was conducted, and they found that 8 states had the authority to share data with authorized users in other states. 18 states have authority to share data with other prescription drug monitoring programs, and 18 states have the authority to share data with both. The study did not go into the underlying authority that each of these states had. I imagine that there's probably 2 main ways that they are sharing data. That's either if it's mandated in law, it's allowing the state to share information interjurisdictionally, or they're using their state police powers to share information interstate. And the states have interstate sharing provisions either specifically in their statutes or regs, or in this study, they said that the administrator of the prescription monitoring program stated that the state allows interstate sharing. So in the cases where they're using police powers, it's probably not explicitly documented. And so the administrator said that that was permissible under state law. Okay, and just to talk a little bit about some federal laws that could impact prescription drug monitoring programs, I'll talk a little bit about HIPAA, 42 CFR Part 2, and then other legislation. So prescription drug monitoring programs are generally not subject to HIPAA because they're not covered entities. So HIPAA defines a covered entity as a health plan, a healthcare clearinghouse, or a healthcare provider who transmit health information electronically in connection with a transaction covered by HIPAA. And a review of HIPAA's definitions indicates that the prescription drug monitoring program is clearly not a covered health plan or a healthcare provider. So the healthcare clearinghouse seems to present a little bit more of a potential. So when you do a more detailed review, prescription drug monitoring programs don't fall under the definition of a healthcare clearinghouse under HIPAA either. A healthcare clearinghouse for HIPAA purposes is a public or private entity that processes or facilitates the processing of information received from another entity in non-standard format or containing non-standard data content into standard data elements or a standard transaction or vice versa. And so that's a pretty long definition. And it seems that most of those elements might fit under a prescription drug monitoring program except for a transaction. So a transaction is the transmission of information between 2 parties to carry out financial or administrative activities related to healthcare. And that's not what a prescription drug monitoring program is doing. They're not engaged in financial or administrative activities for for a hospital or a health service or a health plan. The purpose of the prescription drug monitoring program is housed in public health, public health and safety. I skipped a little. So prescription drug monitoring programs collect, maintain, and disclose information. And they're also not considered business associates under HIPAA either. Prescription drug monitoring programs and 42 CFR Part 2. And just fair warning, I would not consider myself an expert on 42 CFR Part 2, but my boss, Denise Chrysler, is much more, she covers her face, she's much more knowledgeable in this area. But from the research that I've done, and there's actually a letter from SAMHSA to state prescription drug monitoring programs clarifying the applicability of 42 CFR Part 2 to prescription drug monitoring programs. And so generally, they do not meet the definition of federally assisted substance abuse programs. And there are authorized disclosures by PDMPs that are not disclosures of substance abuse patient records. And so SAMHSA concluded that PDMPs generally are not subject to 42 CFR Part 2. There is an exception that they note, though, and that is federally assisted substance abuse treatment programs. So those include opioid treatment programs and Drug Addiction Treatment Act of 2000 waived physicians that are considered substance abuse treatment programs under the federal confidentiality rules, and therefore disclosures of patient identifying information by such programs to state PDMPs are not permitted unless an exception applies that's consistent with federal confidentiality regulations. And there's no exceptions that I know of or could find. And so generally, prescription drug monitoring programs will need patient consent to disclose information under 42 CFR Part 2, and any redisclosure of that information is prohibited. And so SAMHSA's recommendation was that the opioid treatment programs and the Drug Addiction Treatment Act waive physicians do not disclose patient identifying information for PDMPs in that instance. And then I just wanted to mention the Comprehensive Addiction and Recovery Act, and in that the 21st Century Cures Act as well. So the Comprehensive Addiction and Recovery Act provides resources to states to establish, maintain, and improve prescription drug monitoring programs, though it's somewhat of a fallacy, because the resources were, so the 21st century, or the the Comprehensive Addiction and Recovery Act was passed a few months before the 21st Century Cures Act. And the CARA authorized harm reduction strategies, including increased access to overdose, reversal drug naloxone, and for the opioid crisis, but it didn't actually provide any federal funding for implementation of those programs. And so the 21st Century Cures Act was then passed, and it designated $1 billion in grants for states over 2 years to fight the opioid epidemic. And this included money that could be used to improve prescription drug monitoring programs, to make treatment programs more accessible, to train healthcare professionals in addiction treatment, and to research effective approaches to prevent dependency. So the secretary under CARA is charged with awarding state grants for comprehensive opioid abuse, and it provides support to local governments to establish PDMP where state PDMP doesn't exist. So an example of this is St. Louis, Missouri has a PDMP. And then CARA also promotes data sharing and interoperability for PDMPs, so specifically identifying data sharing as a qualified activity for grant funding, and establishing data sharing as a priority consideration for the awarding of grants. But it doesn't provide it doesn't provide guidance about how to harmonize the difference in laws between states, or how to actually manage the data sharing and interoperability between PDMPs. And the CARA also encourages more timely data and regularly updated PDMPs, and so that's included as a priority consideration for the awarding of grants. So if PDMPs are including that in their grant applications, it could increase the chance of funding. So, thank you.
Good morning. I'm probably the odd man out. I'm not an attorney. I don't claim to be one. I know of several. I've been working with them on the Board of Pharmacy and now on the Board of Health for some time in Nebraska. Jennifer gave a great overview of what PDMPs are and some of the legislation involved with them. I'm going to go into a little bit more detail on PDMPs, what they are, and then some of the exciting changes and innovations that Nebraska is doing. Opioid epidemic, we all know it's out there. President Trump declared a public health emergency, which actually didn't do much except get the name out there. I think it was, don't quote me exactly, around $74,000 of funding was made available. But there's a lot that Congress has been doing, a lot of other federal funds that are going on. We all know it's a problem. This slide shows a study that Blue Cross Blue Shield did in 2016 on some 2015 data, just showing that the number of their covered lives and the percent that had an opioid prescription in that time. Nationally, 21.4% of their covered lives had an opioid prescription in 2015. Michigan, 18.6%. Nebraska was a little bit lower, but you can see where different states are in that. Combating the opioid epidemic is not something that you can do with one fell swoop. It's multifaceted, multimodal. Prescription drug take-back programs are a good start. Get those drugs out of the hands of individuals, out of children, grandchildren that go into your medicine cabinets and find those drugs that then go to those farm parties. You have maybe salespeople or neighbors that come into your house asking if they can use your restroom, and they'll rummage through your cabinets. It's unthinkable, but it happens all the time. Education. Education needs to start in elementary school. You need to get it out there young and keep maintaining that message throughout. Pain management guidance documents. The CDC published in March of 2016 pain management guidance document, which helps for chronic pain. Other states have created their own guidance documents off of that, and it helps to improve prescribing practices so you get, in the long term, better prescribing. Treatment and recovery is another one of the pillars that the CDC has. Naloxone, Narcan is widely available, often now without a prescription. You as a patient or a family member can go into any pharmacy and request naloxone. Now, there are some challenges with that. You can be given from the pharmacy vials of naloxone and a syringe. And think of it as a public person. You see someone, a friend, a family member that's down, possibly of an opioid overdose, and now you're trying to pop open the top and draw out the syringe and needle and draw it up and then inject it. Doesn't work very well. It's cheaper, maybe $40 to $60. There's another product called Evzio, which is naloxone in an auto-injector form, similar to an EpiPen, where you can simply just pop the top and inject it into the person's thigh. Works very well. The cost is anywhere, if you go into the pharmacy, patient pays between $4,200 and $6,200 for one dose. So there are some restrictions. The company does have some patient assistance programs, but there's some pretty strict restrictions on those. So, you know, great product, but there's some challenges financially with that. And then most that you'll see with EMS and people who really want it is getting the naloxone nasal spray, which is similar to like Afrin nasal spray. Comes very small tube. You can pop the top and just inject it into the nostril. EMS carries it, and that's going to cost you anywhere as a patient between $140, $170. Much more reasonable, but it can save lives. And that's why EMS is using it all the time. They'll carry it not only for people that they see down, but they may see it themselves. If they run into an individual that may have some heroin or fentanyl or carfentanil, which are literally hundreds or even thousands of times more potent than morphine. And just by smelling that, by getting any of the vapors into yourself or onto your skin, can have an EMS or law enforcement person down. So they carry it for themselves as well and for their partners. So there's some definitely options to help with that. And then identification and monitoring of patients for controlled substance abuse or misuse. That's where the PDMP comes into place. As Jennifer mentioned, PDMP is a large state-run electronic database that pharmacies send their data into, usually on a daily basis. Oklahoma is the only state that requires mandatory real-time or within 5 minutes of that prescription being dispensed. There's some logistical issues with that pharmacies have to have point of sale and barcode scanning and connected to their cash register. You probably have around 3/4 of pharmacies in Nebraska that have that now, but there are some impediments to getting that everywhere. It does cost pharmacies, and without mandates, that probably won't happen real time for the rest of the states. But the PDMP is a great tool to help healthcare professionals. It's oftentimes used for law enforcement in some states, but Nebraska really takes the view that it's a tool for patient safety. This shows a map, and this is from the Bureau of Justice Assistance and Brandeis University Training and Technical Assistance Center, TTAC. I use this site all the time. It's great information. Also, the National Alliance of Model State Drug Laws has some great information, especially they have a great brief on PDMPs and HIPAA. And then the National Association of State-Controlled Substance Authorities are also some great websites and information if you're looking up something for PDMPs or other information on controlled substances. Me as a pseudo layperson, I use those and I can understand them. So you should have no problem understanding most of that yourself. But this shows that most PDMPs are run and operated through boards of pharmacy or departments of health and human services. There are a handful that are actually operated out of law enforcement. Funding, big issue on this. There's a lot of federal funding out there. Nebraska has been able to get 2 federal grants. Many states operate their PDMP through those federal grants. Some have state appropriations. Some operate it through licensing fees. That's something that, if you're trying to get some legislation passed to sustain the PDMP, what if for some reason you don't get a grant or state appropriation runs out? And can you depend on licensure fees from healthcare professionals? Will they pay that information? Do they see the value of paying $10 or $20 or $50 per year to operate that? And that's why I think showing the value of a PDMP is very important to make them want to use it. So most drugs in PDMPs throughout the country have controlled substances, either schedules 2 through 4, most have 2 through 5, such as your opioids. Then you also have your benzodiazepines and stimulants. People forget that even though you might have a huge number, 145 Americans per day dying of opioid overdose, people are dying of other drugs as well. They're dying of benzodiazepines, your Ativans, Valium, Xanax, Klonopins. In Nebraska, 21.5% of individuals who have had a drug overdose death in 2015 died of benzodiazepines. So it's not just opioids. That's where most people are dying. Nebraska is very fortunate that we have a smaller number of deaths, but we still have deaths occurring. Not only from opioids, from benzodiazepines as well. And your stimulants, your Ritalins, Concertas, your Dexedrines. So you can't forget those. But other states are also including drugs of concern. Some states, Connecticut, and there are a couple of other states actually mandate the reporting of medical marijuana into their system. So that's something to think about. And I'm not sure where Michigan is with the whole marijuana issue, but if medical marijuana is through pharmacies, which I think is federally not allowed, it's probably more through a dispensary, then there may be some mandatory reporting of that needs to occur. Just something to think about. Tramadol, before it was scheduled several years ago, people saw that it was being abused, and so states were requiring the reporting of that. Now it's federally scheduled, and so it's mandatorily reported. Some other drugs, carisoprodol or Soma, gabapentin or Neurontin is used for oftentimes of neuralgias or pain disorders, but we're finding that that's being abused more and more, either in conjunction with opioids or sometimes by itself. If these patients are unable to get opioids, they may switch to something else, and gabapentin seems to be another option for them. Although, unfortunately, for those patients that are unable to get their opioids, they're switching to something else. Florida in 2012 had a decrease of 25% roughly in their opioid prescribing, but their opioid overdose deaths increased because not necessarily of the prescription opioids, but you had your heroin, your fentanyl, and your carfentanil, the elephant tranquilizers. So unfortunately, people shift. Their substance abuse disorder doesn't say, oh, I can't get my drugs anymore, so I'll just stay free and clean and everything will be fine. It doesn't work like that. So they're going to switch to something that's easier to get and cheaper to get than prescriptions. The heroin, the fentanyl. And people don't always know how much of what, because, you know, does FDA monitor how well those products are cut by your dealer? How much baking powder is in there? Or is it more pure that a very small amount is going to kill them? So there's a lot of unfortunate consequences to taking their prescription opioids away. This is another graph that shows how different states monitor different prescriptions. And Nebraska considers actually all drugs being drugs of concern, and I'll get into that in a little bit. History of our laws, this is where when I give this presentation, most people fall asleep. Fortunately, I think I have the right audience, so at least your eyes will open up a little bit when you see this. But in 2011 is when Nebraska actually operationalized their PDMP. It wasn't a great system, though. We had some challenges, and it was specifically written to prevent the misuse of prescription drugs. It did not say controlled substances. It said prescription drugs, much broader. And that's what led into something else that I'll be getting into. It's really used as a patient safety tool, as I had mentioned, for healthcare professionals to monitor the care and treatment of their patients. But it also said there was not to be any funding for the program. So go forth, have your PDMP, but we're not paying for it. So that brought some challenges, and that's where MiHIN, the Nebraska Health Information Initiative, the Nebraska Health Information Exchange came about to say, hey, we have an opportunity here. We're going to use a data feed that we already have to incorporate the PDMP into that. So that's where we started. It wasn't great, but it was something. Then finally they said, okay, we see some momentum here. One of our senators had a daughter that died of a prescription drug overdose. So she really pushed on this legislation and helped to sustain it and move it forward even more. So then they got legislation passed to say, okay, it seems to be good. We'll allow funding. We're not going to give you funding. If you can find it, you can have it. So that's where we started applying for grants. And so we had gaps initially in our HIE PDMP. It was voluntary. It did not include Medicaid data. It did not include private pay or self-pay data. So there were challenges within that. And patients could opt out. Nebraska is an opt-out HIE state. So patients could decide they don't want their data shared. Well, it's a small number, about 2.3% of Nebraska residents or patients have opted out. Well, it's a small number, but which 2.3% of patients do you think don't want healthcare professionals to see that information? So that brought some challenges. So after we got the legislative funding, through both the Bureau of Justice Assistance and CDC, we were able to get a new law passed. And this was approved. It was introduced, I believe, on January 18th. It was signed into law February 24th. That doesn't happen, does it? That fast? And it passed on 3 votes in our unicameral. We're different. We have a unicameral instead of a House and Senate. It passed on 3 votes unopposed. There were no opposition votes, and it passed that quickly. So we had a great deal of support. What this did is prevented the opt-out. So in the HIE, we don't have a choice. Patients can opt out. But we created another portal with the PDMP data where patients could not opt out of their prescription data. They could opt out of their health information data in the HIE, but not out of the PDMP data. and it was available at no cost because we had this federal funding now. It was available at no cost for that. And it began January 2017. Then there was a single sentence that said, reporting all prescriptions January 1, 2018. It seems really simple, just write a single small sentence, but the undertaking, the task it took to do this was a lot bigger than that single sentence that the senators just enacted pretty quickly. So we had an update because we allowed delegates or designees for dispensers or pharmacists, but it forgot as an oversight to include prescribers. And so the physicians were up in arms saying, our workflow doesn't work like this. We need our designees. We need nurses to help, just like pharmacists can. So we made a modification to allow prescriber designees. It also granted access and made mandatory training available. As Jennifer mentioned, there's a lot of mandated use or mandated registration. Nebraska, being very conservative, we took the baby steps and started with mandatory training. So if you want to use it voluntarily, you can. You just need to know how to use it. And then it also said veterinarians have to start reporting in 2017, December 31st, 2017. Well, the vets weren't ready for that. There are about a dozen states, 12 to 15 states that require veterinarian reporting, but there's some challenges to that. So, and actually our law goes into effect July 1st of this year. In less than a month, veterinarians are going to report all Schedule 2 through 4 controlled substances. A lot of challenges within that. But, you know, be careful what you wish for, because our law was a little bit broad and just said all dispensers, which would be pharmacists, pharmacies in particular, have to report all prescription drugs. Well, all prescription drugs would include non-human, non-controlled substances. Very important. If Michigan looks at any statutes, take Nebraska's lesson learned here. Be sure to write it in not to include non-human, non-controlled substances. Do you really need to see Fluffy's antibiotic in the PDMP or Fido's heartworm pills? It just garbage in, garbage out. It's hard to make heads or tails out of it. So lesson learned from Nebraska, make sure if you're going to do that to write it in to say Michigan will include all non-human controlled substances, excluding non-human, non-controlled substances. And we clarified some use on that as well. So Nebraska, moving forward with all prescriptions, we were the first state to have the PDMP operationalized within the HIE. We did that back in 2011. Other states have done that, some successfully, some tried it and backed out of that. We were also the first state to mandate all prescriptions being reported to the PDMP. And we really focus on patient safety, not law enforcement. Even though some states allow law enforcement access, Nebraska does not, other than a court order or a subpoena. At one time we were told only a court order, but then, and this legally I don't understand everything, but there is a difference between court orders and subpoenas, and Nebraska has determined that both are allowed to be accessed with the PDMP. So as we're reporting all prescriptions, we're having the most comprehensive medication history available. And this is where it can really shine for healthcare providers, for HIEs, for hospitals, for clinics. It has 10 times the data that normal PDMPs would. Great patient safety tool that allows the healthcare providers to make those better informed decisions. And it's really for MedRec. And I spell MedRec. How many are healthcare providers? Anyone? Got just a couple? I spell MedRec W-R-E-C-K. MedRec, if you know what it is a disaster. It's where the patients have to have a listing for their healthcare providers of all their medications when they're going through the continuum of care, when they're admitted into the hospital, when they're going into a clinic. A listing has to be available and obtained by those healthcare providers. If you go in to the hospital, into the ED, or have surgery, you know, you have probably your nurse, maybe a pharmacy technician, asking you what medications you're on, what's the dosage, did you take it this morning, different things like that. And all this is required to have a better understanding so that patients can have better treatment decisions made. So what we've seen so far in Nebraska, last year alone we had 3.9 million controlled substance prescriptions put into the PDMP. This year, for the first 4 months, 10.5 million. Because we're now collecting all prescriptions. Last year, we were averaging about 10,600 prescriptions per day collected by the PDMP. This year, over 87,000 prescriptions per day on average. So once again, we're seeing 90% of our data being non-controlled substances because we're including things like your blood pressure, your antibiotics, your statins for cholesterol. We're seeing a greater use of the system as well. This graph just shows how much we've increased over that time from December to April is our latest data. And then the queries, this really is more telling. Is the system being used at all? From December to April, we had in December about 9,088 queries in the system. We've had almost 25,000 queries in the month of April, 2.5 times increase because people are seeing the value of this system. And it's more than just collecting all this data and not knowing what to do with it. It's allowing the healthcare professionals to have more information and turn that information into knowledge to make those better treatment decisions for the patients. And we do get some questions about sort of the privacy issues. One of my favorites, and it came from a pharmacist, I have a friend who is on Viagra, and what if he doesn't want that information shared with anyone else? Well, those reasons are why you actually do need that information shared, because if you go into the hospital and you're having chest pain, patients might be started on nitroglycerin. Well, there's a very serious, potentially fatal interaction between nitrates and Viagra and Cialis and Levitra. And so if you try to withhold this information, is it data blocking? Well, I don't think I'd go that far, but you're withholding valuable information that your healthcare provider needs to make better informed decisions. And if you don't give that information to your healthcare provider, and it's a Saturday night when you're going into the ED and you're not able to provide that information and they can't access your pharmacy, they don't know what's going on. So it's very important for your own safety to have that information. So there are a lot of other opportunities for PDMPs as well. Clinical safety alerts that we have, better reporting capabilities. Prescribers want to know how they compare to their peers. So a lot of states are starting to see this data come up. How many patients do I have on opioids or benzodiazepines? What's my morphine milligram equivalency rating compared to others? Having all prescriptions, we're starting to see trends. There are 3 other states that have started to introduce legislation similar to what Nebraska has enacted. So I see a trend on capturing more and more prescriptions than just controlled substances. It's a great opportunity to reduce adverse effects, reduce hospital readmissions, and improve patient safety. Interoperability, definitely recognized by the federal government on that. Jennifer had talked a little bit about that. Interstate data sharing. There are 2 main hubs already. The PMP Interconnect run through National Association of Boards of Pharmacy and the RX Check Hub run through Bureau of Justice Assistance. So between those 2, most states have some type of connectivity, although it's not great. Integration, workflow integration is what's so important that we're seeing as well. And this is where the prescribers want to see more and more of it, to use it in their system, have it part of their workflow, directly within their EHR or their HIE or their HIN, to have that information either through single sign-on or a direct connect. And it saves a lot of time. If, let's say, the hospital's EHR is down for either planned or unplanned downtime, maybe there's a tornado, a natural disaster, and they lose connectivity, usually the EHR may be down, but the HIE, HIN may still have some connectivity and have that data available since the EHR went down. And you see a lot greater amount of data, not just that one EHR. So, preaching to the choir the benefits of HIEs and HINs. And that medication history is so beneficial if you go into the ED and now everyone's paperless. Is that a good thing or a bad thing? Sometimes we wonder because there's challenges with all of that. And how do you make all of this work? So you have all this data, you have this great amount of information, and you turn into knowledge to make those better treatment decisions for your patient. Nebraska's been very fortunate in the approach that we took. We've had the state associations all in support of this. We've had our unicameral, all the senators really have been in support of this. Once again, I said in just about a month time, 5 weeks time, from introduction to enactment of a law with no opposition. That's just amazing. You don't see that very often. The Attorney General has been in favor of this, although they're sort of squirming a little bit because they don't have access to it. They would love to have access. It'll be interesting to see what 2019 brings. Governor's been very much in favor of this as well. And then the federal legislation that there are several bills out there in both the House and Senate that may mandate something such as prescribing limits or interstate data sharing if you want some federal funding from the CDC or Bureau of Justice Assistance. So there's a lot of opportunities there that other states can bring in more data. With that, I have some contact information if you do have any questions for us. And with that, I open it up for anything. Yes? Do we see reduction in opioids deaths so far? I haven't seen the data yet. You know, it's always late. Our system's only been up since 2017, and DHHS is still compiling that data. I believe they have 2016 data, but that's before the PDMP had started, so we are monitoring that pretty closely.
I'm surprised that only one state, and congratulations on that, has it integrated with the HIE. Have you had enough history with it to demonstrate the efficacy of that other states could learn from?
Sure, and there are other states that are doing something similar to that. Washington State has their PDMP within the HIE. It's sort of a different model. They use Epic as their EHR, and it's more of a, through one health port in Washington, a direct connect between their Epic systems into one health port in Washington. Maryland with CRISP does have some access into that. And there are a couple of other states that are also doing that. I believe there are close to a dozen that have either been exploring that or have been adopting it, and either it hasn't been too successful for one reason or another, or they're sort of taking it very slow to move forward with that.
So in Michigan, we just enacted comprehensive opioid legislation, including mandatory reporting, and it just went into effect, so everybody's trying to sort it out. And the legal question, I noticed for Jennifer, you talked about HIPAA doesn't apply to the PDMPs because it's a state run system, but for us the question is the state has hired a vendor, a PRIS, to do linking between EHRs and the state's program, and they also hired that vendor to build out their program, and they're paying for a year for hospitals to get this automatic linking. So the argument was, well, does that vendor need a HIPAA business associate agreement or not? The state is saying no. That's great for the year that the state has hired them as the vendor, but after that time frame is up, then the question is, you know, we will need business associate agreements with that APRIS vendor to automatically link the EHRs to MAPS. And by the way, that vendor also now has a monopoly with the state because they were hired and given that year-long contract. So that's some of the interesting legal issues we're dealing with here in Michigan.
Yeah, so I think when I was talking about HIPAA, I actually skipped over a little bit of what I wanted to say. I had a but as far as whether or not HIPAA applies to PDMPs, and it depends on whether or not the organization that runs or where the PDMP is housed is a HIPAA-covered entity. So in if the PDMP is run by a health department and the health department is HIPAA covered, then the PDMP is then also HIPAA covered. There could be the instance where the health department is a hybrid entity, and so it's designated the PDMP not to be HIPAA covered, and then in that case, it wouldn't need to comply with HIPAA regulations. But in the case of a health department run PDMP that is HIPAA covered, then an organization coming in and doing work for the PDMP, then a business associate agreement probably would have to be signed in that case.
And just to expand upon that, as you said, APRIS does have the contract. APRIS is the vendor that has the contract for interstate data sharing with now approximately 42 states, I believe, for that interstate data sharing. It's all run through the National Association Boards of Pharmacy and what's called the PMP Interconnect. To do that interstate data sharing, it's a simple 3-page MOU that does not have a BA. But to your point, if you're trying to do direct connect within an HIE or EHR, there may be a BA that's required.
And just a quick follow-up on that, I think that's a good point. APRIS is so pervasive. They have the contract for all of this stuff, and they seem to be a reputable vendor that many of our providers use. The problem, though, is it is kind of creating a bit of a monopoly in our states, as your state maybe too, is getting a good deal. The state is using APRIS. APRIS is widely used. The problem is if there are other types of vendors that want to come in and do that linking, they're being kind of shut out of that process, and it might be to the detriment of all of our hospital providers who are paying the bill, because there really won't be an opportunity to get some competitive pricing. So I think just as a quick follow-up, a heads up, because APRIS has been used by everybody, they've created this MOU that seems to be universal. There's not room for negotiation on that. That was some of the back and forth that has gone on recently here in Michigan as we're, enacting this. It's not that it's not a good process. It's not that they're not a reputable vendor, but it's that the state picked them. The state has the BA or whatever with APRIS. There's very little room for the providers to negotiate any type of, language in the contract to protect them. And, come a year from now, APRIS will have the in on this whole linking system, and you won't be able to use anybody else. And so I think that, I don't know if that's an issue in other states, but that's our issue.
Very much an issue. Nebraska actually was recognizing that when we were starting to look for, through our RFI process, and we selected a vendor that has never done it before. Dr. First is our vendor in Nebraska that does this. No other states are using them right now. We've had great success with them, and the federal government is aware that there does seem to be, as you say, a monopoly where there are only 10 to 12 states that are not using them for their PDMP vendor or the connection. The other vendor through IGIS, or the Bureau of Justice Assistance, has about 12 states that do that interstate data sharing. But like Nebraska, we have all of our border states using APRIS. So that makes it a bit of a challenge. If we wanted to use someone else that isn't data sharing with APRIS, then you're almost forced to go that way, strengthening that monopoly. All right, if there are no other questions, I wanted to thank you very much.